I said in my symposium, it is a dogma now, meaning that this is something that is really absolutely clear. We have to treat in MS as soon as we know that we are facing a person with this type of disease. And the first consequence is, should we then also anticipate the treatment at the preclinical phase? Is this necessary to have an attack to define a person as affected by MS? As it is now, of course, we need the attack to classify a person as an MS, but I think that in the future we should really reconsider this type of classification. Personally, I'm in favor to consider MS also a disease where still we did not have an attack, because having or not having an attack depends on the site, mostly, if not exclusively, on the site where the new lesion takes place. So we cannot just leave our diagnosis to the fate of the site localization. I think that if early is fundamental, we should consider to move also to this very, very early phase. The second aspect is that early is not enough. I think that the treatment has to be also adequate to the strength of the disease. We now have a lot of demographic, clinical, and instrumental markers that may help us to try to define the trajectory of the disease since the very early phases. So why then not to use this type of information in order to decide when we should start with an aggressive therapy since the beginning? We have now essentially two major differences between drugs with a moderate effect on inflammation and drug with a strong effect on inflammation. This is a bit an oversimplification. Of course, we have a bit of a continuum. And also for aggressive treatment, we have treatment that act in a different ways. They can be used for a different time. So there's a lot, is much more complex that there's a lot that you have to consider. But again, to oversimplify, I think that today we should first be in a condition to decide when to start immediately with a treatment that is more aggressive. All the evidences we have, also from post-marketing studies, do suggest that this is the best way to protect the patient from the accumulation of irreversible disability.